My name is Donna Dixon. For those of you that don't know me, I actually was a clinical nurse specialist for sickle cell for 23 years. So I took care of all of the patients as a nurse all the way and did all of their patient care management, depending, it didn't matter what it was, all the way from the newborn screening all the way through life. Our oldest patient that we had here in Colorado was 88 years old. So we've done some amazing things over the years. And I actually started working there. I'm gonna tell you my age. I don't mind that. I think I look good. But
Yes,
I
you
started
do.
working for the Sickle Cell Center in 1981. So that tells you how long ago that a lot of the things started that we were doing. And that'll make more sense when I start telling you about the advancements and what kinds of things we're doing now and how that connects with the community-based organization. I was the nurse for 23 years and then I retired in 2004. And my retirement meant that I then became the president of the community-based organization, which is the Colorado Sickle Cell Association. The association has been in place since 1974. And when I was the nurse, I was actually the liaison for the hospital because we partner with the Colorado Treatment Center.
So I wanted to ask you, like, what does Black History Month mean to you?
Black History Month. I am a Denver native. And so just to keep awareness of all of the activities that are going on around Colorado and to make sure that it's not only sickle cell is a disease that has been stigmatized. It has been thought of for some people as a curse. It has so much misunderstanding about sickle cell that only people of color get sickle cell. And so our main mission with our organization is education. It is to support families with sickle cell. And so that means the patient as well as the family members. We also support and put on blood drives for sickle cell. And there's a special reason for that as well, because the disease itself is a genetic disease. It's a disease that if you don't have all the genetics put together properly, you don't do well with the treatment, nor do you do well with any plans to cure the disease. Everything that is surrounding the sickle cell disease itself has to do with the genetics of it. And sickle cell is a disease that has to do with the red blood cells. And it actually was a disease in which all the red blood cells that are supposed to be round, dish-shaped, flexible, and basically all the red blood cells do is they're turned red, they're red, and they carry oxygen. Two jobs. But the problem is if they're not like this, where they just like smash down and move like they're supposed to release oxygen for every place in the body, what happens is they smash down and they look like an old-fashioned sickle, looks like a half-shaped moon. And that's where the problem comes in. Then obviously, if that happens, the red blood cells don't carry as much oxygen as it's supposed to. And obviously we need oxygen for everything in our body just to live. And then it doesn't release oxygen, but if they smash down like that, they'll smash down in the blood vessels. And any place they smash down like that old-fashioned sickle shape, they could smash together, and that's what really causes the pain. They just log jam up the whole blood system wherever that happens. So it could happen any place. It could happen in the eyes, ears, nose. It can happen in arms, legs, and then it can also happen in major organs. And if it happens in major organs, I'm talking about like the brain. So then the people that kind of condition happens in, they can actually have strokes. And the strokes look just like the stroke you see with older people, where they can get paralyzed or the blood vessels can smash down like the people that they where it like kind of like just like burst and just spreads blood every place. And that's like called an aneurysm. and they can die from that. But if it happens in any of the major organs, those major organs, if that happens for a long enough period of time, then that particular organ could stop working and functioning normally like it's supposed to. So it's an ugly disease, and it genetically, you have to have one normal cell, one sickle cell. That's called sickle cell trait. And that actually is found all over the world, and primarily places where you have water, because where you have water, you have mosquitoes. Where you have mosquitoes, you have malaria. And the normal cell and then the sickle cell put together is called sickle cell trait. Sickle cell trait actually protects people from malaria. But the problem is, and essentially what happened is in those areas where you had, the malaria, etc., that again was a protection. But if you had two people where that blood mutation took place with the genes that made that one normal cell and one sickle cell, then those people protected from malaria. But when they get together to have babies, the problem is now the two cells, S and S, can get together. And S and S together, there's a 1 out of 4 chance that that could happen with every single pregnancy between these two people. Well, that S and S is sickle cell anemia. That's where the problem comes in. Now, what's the problem with sickle cell? Sickle cell is the blood count. We already talked about that the red blood cells carry oxygen. Well, normal blood count is about 14. But with sickle cell patient, normal blood count is about half that. So it's about 7. So that tells you right there why they're tired a lot of times, a lot. And then the way the body works, our whole body is set up. Our bodies are amazing. It's built to heal itself. And the ways you see what happens with any type of a condition like that is that the body tries to compensate for everything that it's not doing that it's supposed to. So one of the things that happens is that you'll see people with sickle cell from time to time, the whites of their eyes will look yellow. Well, you heard people talk about bilirubin. We talk about those kinds of nice, fancy medical terms at the hospital all the time. Well, it has to do with the liver, but it also has to do with the fact that it helps to break down all of the blood cells that are not normal. When they go past the system or go past the spleen, for example, they just break down and die off. And that's what you're seeing, that yellow in the eyes. And then, like I said, they're tired. And then, as I was telling you before, those cells can kind of like stack up on top of each other in any place in the body, and that could cause pain. So sickle cell, like I said, it's an ugly disease. That's all I'm going to say. I can't go any place because until we have a total cure for sickle cell disease, I don't think I'm supposed to. So I'm still around. And speaking of that piece of it, the reason I'm saying that is because we talked about that sickle cell has to do with the genetics of it all. Well, in Colorado, we have actually cured over 30 patients from sickle cell disease. And we've done that. We started about 20 years ago. And you've probably heard people talk about bone marrow transplant. Well, that's what happens. And essentially what that means is that you have someone else in the family. Remember, we talked about this as a genetic disease that doesn't have sickle cell disease. You use their genetics, their red blood cells, and transfer them to someone who has sickle cell. Well, they have to, first of all, number one, have the match. And the only way you're going to have the match is these parents have to get together with another child, for example, and have a child that has sickle cell trait, because they can't both have, all of them have S's, because then S's are just going to keep transferring back and forth around each other, and that is not a cure. But if they have like sickle cell trait, or they don't have sickle cell disease at all, but they have the same other genetics in their bodies, and that can happen as well. They can actually use the genetics from the one person and transfer it to the other. Well, we started about, like I said, over 20 years ago doing that. So our first patient that we did a bone marrow transplant with is still living, and he's about 40 years old right now. They're getting better with it because now they're not just transferring the blood just from the siblings, because it's really, really, really hard to find. First of all, think about it. If you have a child with sickle cell disease, how many kids are you going to try to have to get another child that matches, that doesn't have sickle cell disease? I mean, and I'm over exaggerating. It's not that people try to have children just to get a match. That's not what I'm saying by any means. But anyway, what I'm saying, a lot of times people just don't have any more children with that same person if there's a chance that they're going to have another child with sickle cell disease, because taking care of a child with a chronic illness is hard enough by itself. And the chance that 1 out of 4 chances that you could have another child. So we do have some families that have more than one child with sickle cell in the same family. So that's not going to be the answer. And now you hear them talk about stem cell transplant. That's a little bit differently, because now you're actually talking about that you don't have to have a sibling. Then they went to the next step where they could use either the mother or the father. And remember, I told you have to have both of them to have a child with sickle cell disease. And so you're using a half match and either using the mother or the father. And we have several of those as well. We have about 5 of them where it was either the mother or the father that was actually the donor. And we got cures that way. And now we're at the higher level step right now where they're actually talking about the genes in the body themselves. So they don't even need a donor. They take the patients themselves. They take their blood cells, they take them out of the body, and because they know how to do the genetics of it, they actually do a gene transfer, take out the bad gene that causes all the problems with sickle cell, replace that, and then put that blood back into the person. So that's how it's transplanted that way. And we've recently just opened up the gene therapy clinic over at the Denver Children's Hospital. And there are 2 scheduled in the next month or 2 right now, because we work with the hospitals where all of this is taking place. So that'll make us, and at this point, like I said, we've had over 30 that have been cured with from sickle cell disease, but it's not the answer for everybody. Number one, it is extremely, extremely expensive. Insurance have just now started picking it up and not calling it experimental. Okay, so that's one thing. Number 2, to make sure that you have matches still. And like I said, we're just getting to the stage where we don't need matches of other family members, but we could actually use that one person. But the eligibility criteria is amazing as well. It has to be someone who has had, you don't want them to get too old, because the older they get, the more times they probably had sickle episodes that have probably decrease the functionality of different organs in their body. So the chances, if you have organs in your body that are not working like they're supposed to, of them getting through the whole process is decreasing as they get older. And then another piece to that is that you want to make sure that, again, it's worth it for them. If they're going to have a transplant, you don't want to put them through all of that, because you have to literally shut down their whole system with chemotherapy so that they'll accept the blood back and engraft it. Otherwise, it's a waste of time, or the body may reject it, and they call that a graft versus host disease. And they could die from that. So, I mean, there's risk factors still involved, and we're trying to get better and better back. So we're cutting down the number of risks, but at the same time, the criteria for that is really pretty stringent. And we're going to be very careful about those we choose. And we're going to spend lots of time making sure they understand every piece of it. And generally speaking, even whether it's a male or female, because you're going to use chemotherapy and shut down their whole systems and stuff like that, then you're talking about whether they can have children in the future. Do they need to save their eggs? Do they need to save their, all of their fertility type things in order to have families? I mean, there's a lot involved. But again, I think overall, if I look at over this time that we've been able to cure those patients, and I see them at events that we have still, and those kinds of like things. And when you talk to them about all the problems they have with their sickle cell versus being cured from it, if they can get over the hump and get to the place where they can have the cure, so be it. And that's my full wish. And I hope it's something easier than even what we're doing right now. We went to all of the Black organizations in the Denver metro area. We started off like that when we started doing blood drives for patients, because we in Colorado were the ones that found out the information and put it together about the matches. So we don't do just like a blood type and a RH, which you'll hear people talk about, that they're A or B or O positive or negative. We actually do 17 proteins all the way out here. So our thing doesn't sound like A positive. Ours sounds like A, C, D, E, M, S, M, P, S, FYA, and that's a positive or negative, and then LEA, but it's 17 proteins out there. Because once again, genetically, a lot of people of color, some of those letters, those proteins that I mentioned to you, they're negative for. And most people that donate blood are not the same genetic background. So they're usually positive for a lot of those things, except if you're a universal donor or something like that. And then even then, just the universal donor, usually you're talking about O positives and O negatives. But then those other proteins out there that I mentioned, they may be positive for them. You cannot give a positive to a negative, because then you're going to have a reaction. And if they're getting blood on an average of once a month, chances are they're going to have a reaction one day or another, and they could be detrimental to them as well. So we actually went to the Black community. We went to Black doctors, nurses, lawyers, preachers, churches, every place, and we do our blood drives like that. Now, what we do is we're telling the people that that we're looking for specific matches to make sure that they match up with the patients that are going to be getting the blood transfusions. We're not turning anybody away, and we're not trying to act like somebody is better than somebody else or anything like that. You're really trying to, because of the fact that even in the military, there was a time in the United States where the Black soldiers would donate blood, and then they would throw away their blood saying, we don't want to take Black blood. If I'm sick, I don't want Black blood. Well, I promise you, all of the blood is red. And if I get sick, I don't care what color you are. Give me your blood if you match, And so that's where we're talking about with the stigma and with the curse and all kinds of things like that. You're talking about genetics primarily. And if in the United States, approximately 1 out of 400 African Americans that are born here in the United States are going to have sickle cell. Okay, but if I go back to Africa, or if I go to some of the areas where they have more water, more mosquitoes, more malaria, guess what? We're talking about at least 25% of the whole population is going to have sickle cell. So if we have a lot of our families that have come here from someplace in Africa, they're automatically tested. And Colorado was we were number 3 to test every baby that is born in Colorado as a part of the newborn screening. So we know when they have sickle cell right away if they're born in our area. And at this point in time, all 50 states do it on the newborn screening. We have an opportunity to make progress. And not only progress, but actual cure for all of our patients. I mean, and 20 years sounds like a long, long time. but it sounds like a long, long, long time if you have the actual condition. It's not as long if you don't. And if you think about the fact that we've known about sickle cell since about 1917, and they didn't really start doing research on it because, again, once again, some people thought that it only affected people of color. And so the research funding was not there, and just following up on some of the things. In the last couple of years, we have done good. We had one major drug. No, I should say two. We used penicillin for babies when they were first born because it keeps them from having an infection that could kill them. Okay. And then we have something called hydroxyurea. And actually, hydroxyurea is an anti-cancer drug. But what it does is it helps build up fetal cells, which protect the red cells from getting sickling and becoming that funny shape again. And so, but it doesn't work for all of the patients because of their genetics. There's still one more piece of the protein on the side that doesn't click with that particular medication. Do you realize? You don't realize, I'm telling you, this last year or two, now we have about 5 drugs that everybody's testing. So I'm getting all these calls from these drug companies now. And one of the things they're asking me to do from the community-based side, because we have a database of all the patients in the whole state of Colorado, is to talk about, would the patients be willing to try these? Well, one of the things that they keep asking about, number one, is I'm not looking, personally, this is Donna's side of it. I'm not looking for one more drug to treat. I'm sorry. Because every time they go into pain, we know we could take aspirin, we could use ibuprofen, we could use all the way up to the highest drug, all the way up to all the cannabis type things that's out there to take care of the pain. But that's not taking care of the problem. I want the problem cured. That's personally my side of it. And so some of the drugs are when they go to the hospital and they're really, really sick, can they put this extra drug in there, into their IVs to help the pain to go away faster and get them out of the hospital faster? That's saving money for the hospital. That's a good idea. I really want to cure the problem so that I have to go to the hospital in the first place. Thank you. So we're at a good place right now. We're able to do a few more things than we have. And I am presently working. We just got a $70,000 HRSA grant in September. And this particular grant was for us, and we are one of 6 states that got a piece of this grant. And basically what it is to talk to all of our sickle cell families, talk to them about what they think about the vaccines, what they know about COVID. In other words, so I'm going to educate you about everything I know about COVID and the extra things I know about how COVID affects people with sickle cell. And then I'm going to ask you, well, did you get the vaccination? Now, my job is not to convince anybody to get a vaccination. My job is not to tell you that if you got the vaccination, which vaccination to get. None of that. I just want to know, number one, did you get the vaccination? How do you feel about it? And with all the changes of information that's coming out, being a specialty disease, guess what? I have more information than the information you're hearing on TV. I promise you. And then I have to look at how biologically that part of the information that I'm getting, how's that going to affect somebody with sickle cell? Because it's going to be some things that are going to be different. Their immune systems are already compromised. There's already things going on in their bodies that's not going on in somebody else's body. So I need to make sure that I'm trying to cover all my bases. And then my other part of my job is to support the patients and their family, whatever decision they make. If they say, I'm not getting one, I just want to know why. If it's because you have some information that is not correct, that does not pertain to you, I can help you with that. But I am not going to try to convince anybody to do one thing or another. All I need to do is report This is what they said. And that also gives me more information about how I need to clean up and make sure that I have all the most up-to-date information that I can have possibly at all to help the families so that they live longer, but then have a productive life, not just live longer.
How can people help the Colorado Sickle Cell Association?
Yay. Our address is 6795 East Tennessee Avenue, Suite 439. That's Denver 80224. So people could send in checks, they could do whatever. We also have a web page, which is Colorado Sickle Cell Association.org. And on that page, actually, there's a place that says donate or give. And on that page, the funds go specifically straight through PayPal into our sickle cell account that way. So that's how we know how to keep up with our donors from that angle. And anytime we're having fundraisers or anything like that, if we have contact information for people that want that information, we will make sure that people get those kinds of things. Well, thank you so very much. And again, thank you for thinking of us because we need that.
Absolutely.
Yes,
See my sign behind me? You see where I'm at? You see my sign behind me?
I do.
That's
Yes.
what I want. Hope for
Yes.
a total cure for sickle cell.